In this video we're thinking about burns again, and we want to look at what causes burns, the etiology. And of course if you're watching in the States you don't have the A. Now obviously burns can be caused by heat. Most obvious cause of burns. And a lot of burns are caused by moist heat involving hot water, and we call these scalds. So these are caused by hot water or by hot steam. And steam, if it's pressurised, can actually be hotter than 100 degrees centigrade. And scalds are about 80% of the burns we see in children are actually caused by scalds, by hot water. But heat can also cause burns via the mechanism of flames. Things can be burning. This is a more common cause of injury in older children as well as adults. So it can be from things like burning objects, or one we see quite commonly in A&E is different sorts of fuels, so lighter fuel or petrol burning that causes flames. And the heat can also be from hot objects. Where the heat goes directly from a hot object via direct conduction into the tissues of the body. And with heat injuries especially, there's two factors involved. There is the temperature. So the greater the temperature, the greater the injury is likely to be. But there's also the time of contact with the tissues of the body. So for example, research has shown that if the hand is immersed in water at 48.8 degrees centigrade, 48.8 degrees centigrade, after 5 minutes that heat will be sufficient to cause a full thickness injury. But that will take 5 minutes at 48.8 degrees C. But if we have it higher temperature, so for example normally when we're drinking hot drinks, tea or coffee, they're going to be 71 to 80 degrees centigrade, or even higher. We've just poured some boiling water from the kettle. And above 71 degrees centigrade then there can be full thickness injury on contact, and certainly with as the water approaches boiling, full thickness injuries will be instantly caused. So it's the temperature and the duration of exposure we always have to think about. So heat is one cause of burns. And another cause, maybe less obvious, is friction. Friction burns. Now, when there's friction and two things are rubbing together, then I can already feel that my hand is getting hot there, because friction is going to generate heat. So it is quite reasonable to call these burn injuries. And the friction often leads to what we call abrasions. Abrasions are injuries caused by wearing or scraping. And they're usually superficial, but not always, because the friction could cut deeper into the tissues. So friction burns are another cause. Another one you'll probably have heard of is electricity. Electricity as a cause of burns. Now in old-fashioned light bulbs the current went through the coil and the coil would glow white hot. Or in electric fire the current goes through a resistor and it generates the heat. And it's the same with the tissues of the body. As the electrical current passes through the tissues of the body, it'll experience resistance, and that will generate heat. And unfortunately, throughout all generations of humanity, very few people have been unfortunate. They've been killed by lightning, which of course is very high voltage electricity. But more common, we come across electrical burns from alternating current and from direct current, the two forms of electricity. So alternating current from the normal domestic voltage in houses, factories. Direct current increasingly common now because it comes from solar panels, and solar panels can generate very high voltages, and a much lower voltage of direct current is needed to cause death compared to the voltage of alternating current. But the problem with alternating current is when you're in contact with it, it can cause tetany, it can cause spasm, and you can be unable to let go of the object causing the electrocution. And of course, with electricity, we need to look for an entry wound, and we need to look for an exit wound as well. Another cause of burns, radiation. We can see this in hospitals sometimes when we do deep X-ray therapy for malignancies, that it can burn the skin. But most commonly, of course, this is from the sun. The ultraviolet light from the sun, and the ultraviolet component of the light tends to damage the skin directly. The infrared component carries the heat and can cause burning. So radiation as a cause. And then the other kind of burns we talk about are chemical burning. And chemical burns are more common in less economically developed countries, unfortunately. But these can be caused by acids, and they can also be caused by alkalis. So acids, you might remember, are low pH. pH is to do with the negative log of the hydrogen ion concentration, but you can think of it as a power of hydrogen, the amount of hydrogen ions released in solution. So low pH is like, well, technically an acid is 1 to 7, but low pH is a 1, 2, 3. Can cause injury. Well, any acid can, if it's in contact with the skin for longer durations. So for acids, we might think of that's quite a few. Carbonic acid, white phosphorus, I do hope you're not unfortunate enough to come across white phosphorus injuries from shells, bombs, whatever. More commonly maybe sulfuric, H2SO4, hydrochloric acid. Sulfuric acid is quite a common one because this is battery acids, and you might have come across patients who've been the victim of these evil acid attacks. Often sulfuric acid is being used for that. And the acids will damage the tissues directly. But acids also cause what we call a coagulation necrosis. So what they will do is the normal blood vessels, taking blood to a tissue, as we know. There's an arterial branch taking blood to an area of tissue. The area of tissue there, or there, that's normally perfused. Then there can be blood clotting. The acids can induce blood clotting. That's the coagulation, and then as a result of that, the blood's not getting to the tissue, so we get an area of necrosis. Whereas alkalines actually, alkalines dissolve protein and collagen. Actually, they will physically dissolve tissues, and can therefore cause deep tissue destruction, and again they'll cause necrosis. Will cause death of tissue in exactly the same way the acids will, but the alkalines do it by dissolving the tissues, and very nasty wounds can result. So this can be things like cement or plaster for plastering walls, hydrocarbons, tar is alkaline, ammonia, all alkalines, and these have pHs that are high. So one would be strong acid, 7 would be neutral, and 14 would be a strong alkaline. So ammonia, for example, in reasonable concentration, has got a pH of 14. So some different causes of burns there. Not just simple thermal injuries. A few other things interesting to think about, and we do come across these. Also, we could, all of these really can be intentional or unintentional. So we could include all of these here, really, all of them, and decide whether they are intentional or unintentional. Hopefully most of the ones you come across will be unintentional, they'll be pure accidents. But unfortunately we do see quite a lot of intentional burns. We've already mentioned acid attacks. Tends to be children and vulnerable people, like a vulnerable elderly, that are victims of intentional burns injury. So for example, if a child had, these are a child's feet here, the legs and feet. It'd be quite common to get a burn on one, of course, but if there was sort of bilateral injuries and there was burning below a particular level on both sides, that's an indicator that it may well be a intentional injury, because the child has been dipped into hot water. Dipping injuries, we would call these. Or another cause of unintentional injuries is cigarette burns, which will cause small areas of full thickness in injury. So do bear that in mind, the intentional or the unintentional. Of course, all this ties in quite nicely with prevention as well. Prevention of burns is so important, our role as health educators and health promoters. A lot of burns we see in A&E departments are certainly children, not all by any means, but we see a lot in children. So do think about children in the kitchen, especially transferring hot fluids, transferring pans. Do think about loose flexes that a child could grab. Think about fire guards. Overseas, I've come across quite a few in less economically developed areas of people working with plastic. Heating up plastic to remold it or to melt it or to use it as a fuel. Gives off very toxic fumes, plastic, such as dioxins. But also it's prone to explosions, and if it comes in contact with the skin, it sticks and causes really quite nasty injuries as people try and work with plastic in the domestic situation. And always think about risk groups as well, children, the elderly, and the big risk groups, particularly for all forms of burns really. Two big risk groups are alcohol users. I wouldn't like to give you a figure, but an awful lot of people that come into A&E department with any form of burns have been using alcohol. And the other risk is smokers, of course, for the direct flames effect. So just a few causes of burns and a few basic thoughts on how to prevent burns. So carrying on with our series of burns lectures, we want to think about first aid. How do we manage burns that occur in the home situation, in the work situation, in any pre-hospital sort of area? Now, if we think about thermal burns first, which is probably the most common we'll come across in the first aid situation. Thermal burns. These are burns, of course, caused by heat. So the first thing we need to do is to remove the heat source. Take away that which is generating the heat. It's fairly obvious. So this could include things like extinguishing any flames. For example, if someone's clothes were on fire. And we would normally do this by smothering it. So ideally a fireproof cloth or any damp cloth would be good, ideally fireproof. And we would smother it because, of course, fire needs oxygen in order to burn. And if we take away the oxygen supply, the fire will go out. And a classic example of this is a chip pan fire where if there's burning fat, the disastrous thing to do, of course, would be to put water on it where the water would splash up all over the place and the fat would splash up, causing facial burns. Although this does sound ridiculous, we do actually sometimes see it in the A&E situation that someone's put water onto hot fat. The correct thing to do, of course, is to smother it with a damp cloth. So that's fairly obvious, putting out the flames. But if someone has been exposed to a lot of heat, then the clothes that they're wearing will be very hot as well and will stay hot for some time. So remove hot clothes. Because even if the flames are out, the clothes will remain hot for some minutes and will carry on burning. And we can remove them, and if we can't remove them, then we would want to douse them with cold water. And the only time we shouldn't remove clothes is if the clothes are sticking to the skin. Especially some man-made material can melt and actually adhere to the skin. And if we were to remove them, we'd be pulling off and damaging the skin at the same time. In that case, we would just cool them off with cool water, wetting them with cool water. So we've got remove the heat source. And then we need to remove the heat from the tissues. Now the idea here is that once the tissues have become warm, or hot, once they've heated up to the point where they're damaging the tissues, then tissue is actually a fairly poor conductor of heat. So what will happen is the tissue will remain hot for a long period of time. And of course, as it remains hot, it's going to carry on conducting into undamaged areas and increase the size of the burn. And as it remains hot, it's going to increase the level of necrosis caused in the burnt area as the heat continues damaging the tissues. So having removed the heat source, we need to remove the heat from the tissues. And the way we do this is with cool water. Now the idea here is we don't want the water to be warm because we're trying to remove the heat, obviously, and the heat differential, the greater the heat differential, the greater the amount of conduction out of the tissues. But at the same time, we don't want the water to be cold, because if the water's cold, that's going to cause a peripheral vasoconstriction. It's going to narrow the blood vessels, there's going to be a reflex. And that's going to reduce the amount of blood going to the area, and the blood circulating through the area is actually another useful way that heat is removed from the tissues, as blood plays its role in distributing heat equitably throughout the body. So cool water that's not causing vasoconstriction. And it's surprising how many people don't realise that this needs to be kept in cool water for 20 minutes. To remove the heat. So the heat is not removed quickly, it takes time. As we've said, tissues are poor conductors. So we can either immerse it in cool water or we can shower the person with cool water, but we need to do it for 20 minutes. And the cool water also has a good analgesic effect. It's very soothing. And what happens in my experience here is that people have been in cool water for about 10 minutes. The cool water's taken the pain out of the burn and they think, oh, that's it, I'm fine now, I'll just get out. But in actual fact, they need to stay in for another 10 minutes because it should be 20 minutes to remove the heat from the tissues. And if you imagine you had a hot piece of beef, for example, and you just poured water over it for a minute, then you cut it open, it would still be warm inside. And that's essentially what human tissues are. And as well as cool water, we can give pain relief. Once the cooling is, once we've had the 20 minutes, do give pain relief. Give analgesics. And here we can use simple analgesics, so we can use paracetamol, that's acetaminophen in the US. We can give a gram of that to an adult, proportionally smaller doses to children, of course. We can give 400 milligrams of a non-steroidal anti-inflammatory such as ibuprofen, and we could also give codeine, maybe 30 milligrams if that was available. And giving those together provides a synergistic analgesic effect. So it's good to remove the heat from it, but also people with burns, we have to remember, it depends on the environment, but people with burns are actually prone to hypothermia. And of course, water is very cooling systemically. So we want the cool water to cool the area locally, but we want to avoid systemic cooling. So we want to avoid hypothermia. Because hypothermia is a complication of burns, so the patient needs to keep warm. So cool the burn, keep the patient warm. So we've removed the heat source, we've removed the heat from the tissues. Now the next complication with burns, and it's a huge complication with burns, and it's a life-threatening complication with burns, is infection. So the next thing to do is to prevent infection. So we need to prevent contamination of the wound. We do not want this wound to be contaminated with bacteria. And the best thing to do here, once we've cooled the wound down, is cover with a clean, moist dressing. This is probably the best way if we need to transfer someone to hospital, just to cover it with a moist dressing. And the other thing that's good for burns is cling film. Just simple kitchen cling film, or we could use a plastic sheet even, clean one. Now, just simple cling film. This cling film here, you can just lay that over the burnt area, and that will cover the burnt area, and it's actually keeping the bacteria out. So if there's a burnt area there, it'll keep the bacteria out. And it's also good because the burn will naturally release inflammatory exudates, which are moist. So the cling film will keep the moisture in, promoting a moist wound healing environment. And because it's the body's own tissues, the inflammatory exudate should be sterile unless it's secondarily contaminated. But even relatively small burns are at great risk of infection. Infection is the great risk with burns. And if we can prevent it in the first aid situation, that is a remarkably good thing to do. So there we have the basis of treating the first aid treatment of thermal burns. Fairly straightforward, but a few things to get right. Notice we're not using any fats on the burns, we're not putting butter on the burns, we're not using any of these traditional folk remedies. It's very simple. Remove the heat source, remove the heat from the tissues, prevent infection. That is the role of the first aider in burns. And it's useful to think while we're doing this about chemical burns. So think about chemical burns now as well. Now, people often think about neutralising acids with alkalines and alkalines with acids, and there's no great evidence that this is effective. But what is effective, if there is a dry powder, if someone's got a dry powder, then brush it off. Normally the powders, the acid and alkaline powders, for example, are only going to be a particular problem when they get wet. So if someone spills a plaster or cement on their skin, we can brush that off. And as long as the skin keeps dry, it shouldn't be too much of a problem. But of course there will be a residue left. And for that we have to wash. So once it's brushed off with chemical burns, we'll then wash off. And we use large volumes of water. Just large volumes of water. Run it for a long time. But we do need to stress we need to irrigate with large volumes. For example, very often in the A&E situation, we get people with cement or alkaline powders, sometimes acids, in their eyes. Particular problem in the eyes. And of course in the eyes, if there's powder blown into the eyes are moist anyway, so the alkaline is quickly activated. And indeed we do keep pH indicators in the eye room to check for acids or alkalines in the eye. But we don't neutralise it. What we do is we wash it off with large volumes of 0.9% sodium chloride, normal saline, isotonic saline. So what we'll often do is put some local anaesthetic into the eye and then set up a normal intravenous giving set without the needle and irrigate the eye for about 20 minutes. And again, patients get bored. They think it's done after 5 minutes, but often it's not. Then after 20 minutes of irrigation, we can check the eye again with a pH indicator to make sure we're getting down towards a normal physiological neutral pH, which is what we want. So again, nothing clever. We're not invoking chemistry. We're not neutralizing acids and alkalines. What we are doing is irrigating with large volumes of fluid. Now if we think about electrical burns, now obviously here we want to remove the current. So ideally disconnect the current at source. And you might remember that we said with a direct current, small voltages, relatively small voltages, can be very dangerous. And with alternating current, also dangerous, but like a 100 volt shock AC and 100 volt DC, it's the 100 volt DC shock that is much more dangerous, the direct current, because the alternating current switching on and off usually 50 times a second alternating current. But the problem with alternating current is it can cause tetany, and the person can end up gripping onto the thing which is electrocuting them. And when we're rescuing these patients, we have to be very careful not to electrocute ourselves. So if there's water around, that's going to increase the conductivity. But whether there's water or not, we don't want to touch these patients if they're being electrocuted. So we need to disconnect the source, ideally by switching it off, disconnecting the source, or pulling them away from the source, but making sure we insulate ourselves from the patients. So if we're grabbing them, we could grab them through a large bundle of some insulating material, depending on the voltages, of course. If it's very high voltage, even that would not be adequate. So do think about your own safety there. Burns caused by radiation. I mean, the key thing here really is mostly sunburn is the problem here. It's to try and prevent it. Once the burn is caused, of course, we want to prevent further burning, so remove from the radiation source. So any sunburned area should be protected from any further sun completely with full covering of clothes. And we can also have an analgesic effect by dampening the burnt area down with a damp cloth. But unfortunately, once the damage has occurred, and the inflammation often presents some time after the injury, there's nothing really we can do to reverse the damage that has already occurred, just stop any more from occurring. So, a few simple guidelines there. Looked at thermal burns, chemical burns, electrical burns, and radiation burns. Well, welcome to this series on burns that we're continuing. Now, this is a bit complicated, so you might need to make your own mind map to follow this fully. But how are we going to classify burns is the question and the topic of this video. Now, burns can be superficial. Just involving the top part of the skin, just involving the epidermis. And these are sometimes called first-degree burns. So they can be superficial burns. But if they're a bit deeper, then we get what we call partial thickness burns. And these are affecting part of the thickness of the skin. And these are sometimes called second-degree burns. Now, clinically it's very useful to divide these partial thickness injuries or partial thickness burns into a fairly obvious division: shallow and deep. So the shallow are sometimes called superficial dermal injuries because we're talking about the dermis of the skin, and the deep are burning deeper into the skin. But we'll see precisely what we mean by this shortly. Another classification is full thickness. Full thickness burns, and these are sometimes called third degree. And in full thickness burns, the full thickness of the skin is burnt away and destroyed. And sometimes we talk about fourth classification. These are deep. And these are ones that burn away more than the skin, so they go down to the muscle fascia and into the muscles, or even down into the bones. They are deeper burns, and these are, of course, sometimes called fourth degree. So that's the bit you've got to understand first, otherwise nothing else will make sense. So burns can be superficial, the first degree. Burns can be partial thickness, the second degree. And remember, we're dividing the partial thickness into shallow and deep. They're both types of partial thickness injury. Burns can be full thickness, the third degree, involving all of the skin, or they can be even deeper than that, so-called fourth degree burns. Now, I think what we need to do now is do a little bit of anatomy and physiology just to make sure we understand what these classifications mean. So let's move on to that. Now, you're probably vaguely familiar with the anatomy of the skin, but we have the surface of the skin there, and the first layer of the skin has a wavy junction between the first layer and the second layer. Then we have usually a thicker second layer, this layer here, and below this we have subcutaneous tissue here, often adipocytes initially, fatty tissue in the subcutaneous area. Beneath that, in a limb for example, deeper down we'll have the muscle fascia underneath that, the coating of the muscle, the fibrous tissue around about the muscle, and below that we'll have the muscle and then the bone. So that's sort of the layers as we go down. So we notice that the top layer of the skin is the epidermis. We notice that the middle layer of the skin, this thicker layer here, from the base of the epidermis, the so-called germinative layer, all the way down to the hypodermis here below. This area is hypodermis. The subcutaneous area. And they are the layers of the skin. And there's some other anatomy it's essential to grasp as well before we go on, to understand the clinical features that we see when we consider how to diagnose different types of burn. And that is that throughout the dermis, so sensory nerve fibres will come in and they'll branch into many branching fibres like this. Apparently blind-ended fibres like this. And these are found throughout the epidermis. But interestingly, they don't actually extend into the epidermis, so they're just in the dermis. Remember, this layer here is the dermis. And these structures that we've drawn here, these sensory neurons, are the nociceptors of the dermis. Now, the nociceptors are sensitive to pain. So at the moment in my fingers, I'm glad to say I have no pain in those fingers. That means the nociceptors are not being activated, they're not being depolarized. They're maintaining a neurological resting potential, but they're not depolarizing, giving rise to pain. It's only when these are injured that there is pain, so if these are cut or rubbed away or burnt, of course, then the nociceptors generate pain. So it's the dermis that contains the nociceptors. Nociceptors are not found in the epidermis, and there are very few nociceptors in the subcutaneous areas as well. The adipose layer is not very sensitive to pain. It's the dermis that's the pain sensitive layer. So that's important to realise. And the other thing it's important to realise is that the dermis is the vascular layer. So here we have the dermis, and this is vascular. Now, there's very few blood vessels in the adipose-based fatty hypodermis. Very few. So if you touch fatty parts of the body, they often feel cooler. There's less blood vessels in the fatty tissues. Fatty tissues are not well perfused with blood. And likewise in the top layer, remember that's the epidermis. In the epidermis there are no blood vessels. The vasculature does not extend into the epidermis. But the dermis is rich in blood vessels. So what we have is arterioles carrying blood into capillary networks, untold millions of them in the dermis, draining out via venules in the vascular dermis. So what we have are dermal capillaries, millions of dermal capillaries, the arterioles of course taking the blood in, the venules taking the partly deoxygenated blood away. And these are in the dermis, and they're also in the fingernail beds. So what we see is when we apply pressure, let's apply pressure to my fingernail beds here. Right. Apply pressure there. Can you see it's going white? So maybe a bit closer. That's going white, and then as I let go, it's reperfusing. Now that whiteness we call blanching, and the redness going back in we call capillary refill. You can do it anyway. So we press and we get blanching, we let go and we get refill. Now the reason for that is when I'm applying pressure, so when I was applying pressure on the surface of my skin there, that was squeezing the blood out of these capillaries in the dermis. So the capillaries of the dermis are carrying the red blood cells, the erythrocytes. It's good because it means they're giving oxygen to the dermis, they're taking up the carbon dioxide, they're providing the nutrients, they're taking away the nitrogenous waste products, it's all good. But when we press that, what we're doing is we are pressing the blood out of the capillaries. Basically we are squeezing the capillaries shut. It only takes a pressure of about 25 millimeters of mercury actually to close off the capillaries. So we're closing them, and when it's white, what we're looking at we're looking at the dermis without the blood in the capillaries. It's blanched, it's white. Then when we let go, the blood pressure pushes the blood back in and we get the capillary refill. So that's what's going on. Now these injuries we mentioned, the superficial injuries, are injuries where only the epidermis is affected. So they're only affecting the epidermis. So a superficial injury might be something like that, where just the top part of the epidermis is burnt away. Or they might be slightly deeper, where more epidermis is burnt away. But what we can see here is we've got preserved epidermis here. This will be an area of preserved epidermis. That's still classed as superficial because healing can occur upwards and readily from these areas. Now if the burn is affecting more of the skin and it's going down to there, can you see now all of the epidermis has been burnt away? That's all burnt away now. And that we would call a superficial partial thickness injury or a partial dermal injury. But if the burn's more severe, it's going to go further down and it's going to burn away a large part of the dermis. And we will call that a deep partial thickness injury. So down to here, if all this is lost here, that would be a deep partial thickness injury or a deep dermal injury. And if all the skin is lost all the way down to the hypodermis, then we would classify that as a full thickness injury, where everything is lost all the way down. So that would be a full thickness injury. And I've actually got a copy of this from the pathophysiology notes book that you might be familiar with, where I made a note of that. So here we have the classification of burns into superficial, partial thickness, shallow and deep partial thickness, full thickness and deep burns that we've already considered. What I want to do now is look in more detail at the superficial types of burns. So burns, as we see here, can be superficial, and these superficial burns are sometimes called first degree burns. And what we're talking about is when we think about the skin, we've got the epidermis on top, the wavy line between the epidermis and the dermis below and the hypodermis below that. So this is dermis, this is epidermis. Superficial burns are affecting the epidermis only. So that area there could well be burnt in a superficial burn. So superficial, we're talking about the epidermis only, affecting the epidermis. The top layer of the skin. Now, we have mentioned that the epidermis does not contain the pain-sensitive nociceptors, and yet these burns are still painful. Superficial burns can be really surprisingly painful. And the reason for this is, even although the nociceptors are in the dermis below here, so this is where the nociceptors are found, the inflammatory reactions set off by the inflammation set off by the burns cause a lot of inflammation. So the inflammatory changes will go further down from the burnt epidermis into the dermis, and will certainly stimulate the dermal nociceptors as the inflammation goes from the epidermis down into the dermis. So they are still painful injuries. Now, very often these injuries are dry and red. Now, the reason they're red is probably fairly obvious. It's the inflammatory reaction. In inflammation we get heat, pain, redness, swelling, loss of function. So the inflammatory reaction, of course, is going to make it go red. But they often tend to be fairly dry because, as we've mentioned before, the capillary networks are going to be in the dermis. They're going to be in the dermis below. And the blood and the plasma coming through these capillaries is what brings the fluid component. So we have a lot of tissue fluid in the dermis naturally, but not so much in the dermis. So they tend to be dry because the epidermis because the dermis rather with its blood supply is spared. And I think you can also see that because the blood vessels in the dermis are preserved, then we're still going to get the blanching effect. So when we apply pressure on here, it's going to squeeze the blood out of these capillaries. When the blood's squeezed out of the capillaries, the redness is squeezed out of the dermis, and we'll get this blanching effect. So we'll get normal blanching in superficial burns. So they're going to blanch pretty well as normal skin will because of the preserved dermis. Now, along here between in this junction, if we just blow that up a bit, in the junction between the dermis below and the epidermis above, sitting on the base of the epidermis we have the germ cells that are dividing to produce new skin. And in superficial burns, these cells, these stem cells, they're actually keratinocytes, will carry on dividing, and the cells will move up the way, completely healing the epidermis, allowing healing to occur without scar formation. So healing from the germinative layer is normally fairly quick. So these cells will divide and they will replace the damaged part of the epidermis above fairly quickly. There's a high turnover rate in skin cells anyway, so we'd expect fairly rapid healing in superficial first degree burns. Well, here we have our overall classification that we've been using. First degree, superficial burns affecting the epidermis. Partial thickness burns, second degree burns going into the dermis. Full thickness and deep. So we want to look at the partial thickness in this clip. So as usual here we have the diagram of the skin to orientate ourselves. We have the dermis here and the epidermis on top. And we're talking about these burns which are superficial dermal. Now actually this term's slightly confusing. Superficial, we tend to think of superficial burns affecting the epidermis. So really the better term here is shallow dermal. They're affecting the top part of the dermis. Now the area that's burnt here is going to be, we're going to lose all of the epidermis and their partial thickness, so they're affecting part of the thickness of the dermis. So the burn might occupy an area such as this. This area here can be burnt, losing all of the epidermis and losing some of the dermis, losing the superficial area of the dermis. It's a shallow dermal burn. So how might we recognise burns of this nature? Talking about superficial or shallow dermal burns affecting the superficial parts of the dermis. Well, we know that in the dermis there's lots of small blood vessels, arterioles, capillaries, millions of capillaries, venules. The dermis is well perfused with blood vessels. So when there's a burn, there's going to be inflammation, and the inflammation is going to cause quite profound capillary vasodilation. So if we think about the normal capillaries, the walls of the capillaries are something like this. They have, that's the nucleus there, the vascular endothelial type cells. That would be a normal capillary. The lumen in the middle, the red blood cells going down the lumen, of course. What happens in the inflammatory reaction is these vasodilate, they move apart. So if you imagine that my hands are the cells in the wall of the capillary, when they move apart, can you see there's now gaps left in between the cells? And exactly the same thing happens with the inflammatory process. And as we know, burns cause a lot of inflammation. So these cells move apart in the vasodilation, like this. So the cells have dilated and moved apart, and this greatly increases the permeability. So what this means is that whereas here there was only small gaps for the water to get out from the plasma, or the plasma component of the blood rather than just water, now there's great big gaps, so huge amounts can get out. We've increased vascular permeability as a result of this inflammatory process, and we get a lot of tissue fluid going out into the tissue spaces here. But of course this is all lost here, so this is now the surface. So all these tissue fluids, the inflammatory exudates, the inflammatory fluids are now in the base of the burn. So what we find is that these superficial burns are moist and weeping, or a better term is exuding. So the shallow dermal burns are moist and exuding for that reason. Now in some areas the epidermis is not burnt away, it's still there. It's still there, but it's dead because it's been burnt, it's dead. But can you see that means we've got a situation now where we've got lots of tissue fluid, but the epidermis is still there. So the tissue fluid's got to go somewhere. So what happens is the tissue fluid just collects underneath the dead epidermis, and that is what we call a blister. So fluid loss, blistering. And also here we notice that there's that should be a separate point really. We have exposed nociceptors. So we've got the fluid loss and the blistering, and we've got exposed nociceptors. So the fluid loss, sorry, the blistering rather, because the fluid is collecting underneath dead tissues. Now the exposed nociceptors. Now we have noted that there are lots of nociceptors in the dermis. The dermis is where we get most of the nociceptors. There's no nociceptors in the epidermis above, but there's lots of nociceptors here. And can you see now that these nociceptors, these pain sensitive fibres, are now exposed to the necrosed, burned area. So that's going to stimulate the nociceptors a lot. There's going to be lots of depolarizing in the nociceptors. And of course that's what goes to the brain and is, well, into the, wherever it is, into the central nervous system. And it's experienced as pain. So these burns are very painful. And how do we know how deep the burn is? Well, one of the main ways is the amount of blanching, the amount that they'll blanch. So remember, the blanching goes white, capillary refill to fill it up again. Now, do you think you'll still get blanching in shallow dermal injuries? Well, the answer is that you will, because we can see here that the vasculature, the arterioles, the capillaries and the venules in the lower part of the dermis are preserved. So when we press on there, it'll still go white. When we let go, there'll still be blood going through the preserved vascular elements in the lower parts of the dermis. So we'll still get blanching. So we press and we still get blanching. An important clinical observation. So we've got fluid loss, moist wounds, we've got blistering, we've got great pain from the exposed nociceptors, and we've got preserved blanching. Now, what are the implications for healing? Well, healing is normally 7 to 21 days, as long as we can keep the wound moist and keep the infection out. Healing is in 7 to 21 days. And there's preserved deep structures. I'll show you what that means in a minute. Preserved deep structures. Because we preserve some epidermal keratinocytes. So epidermal keratinocytes are preserved in the lower areas, well, in the lower areas of the dermis, and that means we can regenerate. We can get tissue regeneration. So quite what does this mean? Well, what we have, if we take the skin, there's deep structures going into the skin. So here, for example, we have a sweat gland going into the dermis. And on this diagram, the epidermis is going to be here. So we see that the sweat gland goes through the epidermis down into the dermis below, because this is the dermis below here. So we see that the sweat gland is in the dermis. And also there's hairs. So here's a hair follicle, and these can be very deep structures. These can go way down, actually, even sometimes to the hypodermis, the hair follicles. So here's a hair follicle. And the wavy line between the epidermis and the dermis, and the hair root is going to be down here. Let's have a green hair this time. Here's the hair root down here, forming the shaft of the hair, going up the hair follicle, giving us hair, which is good. But the key thing from the healing of burns perspective is, and the healing of skin injuries, which is fascinating, is that these cells on the top, these are keratinocytes that form the epidermis. So the epidermis is made of keratin sites. We notice the term there, keratinocytes. Cells that produce keratin. So the epidermis is mostly keratinocytes. But these keratinocytes actually go down and line the sweat glands. And the keratinocytes also line the hair follicles all the way down. In fact, there's keratinocytes right down at the bottom here because they divide and actually give rise to the hair, because hair is mostly keratin. So that's going all the way down, same on that side, they're all lined with keratinocytes. Now, if we think of wound healing as being in two parts, there can be a fibrosis, or there can be this other term, regeneration. We can get regeneration of the tissues. Regeneration. Now, fibrosis leads to scar tissue, whereas regeneration is a kind of new for old type policy. And cells can only reproduce themselves by this process of mitosis. Simple cell division. Now, if you imagine the situation where we've got a shallow dermal injury and all this up here is lost. Now, here we've lost the thickness of the epidermis. And if you think about a situation where you've got no rabbits in a field, then you go back next year, there's still going to be no rabbits because they can't reproduce. But if you've got 2 rabbits, you'll go back and the field will be full because they'll reproduce. So we've lost all of this epidermis, so there's no epidermis to mitotically divide, to heal by regeneration, which is what we want, because we want to replace the keratinocytes. So isn't it fortunate that we've got spare keratinocytes down here and spare keratinocytes all the way down here? And when there's injury, cytokines released by the injury will stimulate mitosis in these keratinocytes. There will be increased rates of mitosis, and these will migrate upwards and they will form a new epidermis. So that means we have an epidermis produced by regeneration rather than scar tissue produced by fibrosis. And this means that if these shallow dermal injuries are well managed, we can get regeneration of the epidermis. That means we get good cosmetic results because we get new skin, which is great. And it also means we get good functional results because we don't get the scar tissue in the contractures. So because of that underlying design, anatomy, physiology, that means we can get good regenerative healing in the superficial or the shallow dermal injuries. So recognise them: the moist and weeping, fluid loss, blister formation, exposed nociceptors causing pain, retain blanching, healing from preserved elements, preserved epidermal elements that penetrate down into the dermis. And it's a good thing that the epidermal keratinocytes can regenerate, meaning we can heal without scar tissue formation, providing you manage the wound well, of course. So we've looked at superficial, and we've started looking at partial thickness burns, and we've just looked at shallow partial thickness burns. Now we want to look at deep partial thickness or second degree burns. And these are burns that are going to go deep into the dermis. So they are deep dermal burns. Deep dermal. They're still partial thickness, but they're deep partial thickness burns. Now, To orientate ourselves as usual, for these deep dermal partial thickness burns, we need to think about the skin. So here we have the surface of the skin, the epidermis, and the dermis below. Dermis, epidermis, I'm sure you're getting the hang of this by now. Now, deep dermal burns, deep partial thickness burns, they're partial thickness because part of the skin is going to be burnt away. But these are deep dermal. So the superficial burns were affecting the epidermis. The shallow dermal, still partial, these are partial thickness, but they were just affecting the upper part. They were burning down to the upper part of the dermis. But the deep dermal are going to be much deeper burns, going deep into the dermis. So all this is lost. They're not quite going all the way through, so we can see there's still some dermis left here. Still some left, but not a lot. A lot of it's been burnt away. So how are we going to recognise these? Well, in the deep dermal burns, there's still going to be swelling and fluid loss, because there's going to be some preserved vasculature deep down in the lower parts of the dermis. So there might be a few small capillaries left down here. And a lot have been burnt away, but there's going to be some left. So we can still get the swelling of the inflammatory exudates and the fluid loss. Now, appearance-wise, these can be red, but often they're white in colour. And the reason for that is all this tissue on top has been burnt. This is all now dead and devascularized. And the devascularized tissue often appears white. Later on it can go black, it can necrose, but often in the early stages we see a whitish colour to the wound. Although it still can be red, because remember, there's still the opportunity for some inflammatory reaction from vasculature deeper down in the dermis. Very often these have a wet or a waxy dry appearance. So these wounds are typically not as wet as the shallow dermal, because of course in the shallow dermal there's a lot of vasculature left, but in the deeper dermal less vasculature left, and very often we get this waxy, white, waxy, dry looking appearance. And given that a lot of the blood vessels have been damaged, we're going to get reduced or absent blanching. So the blanching effect is going to be reduced. And the reason for that is the blood vessels here, which would have blanched normally, blood vessels that should be here, of course, are just burnt away. They're no longer there. And the only ones left to blanch are the small, limited number that are left deep in the dermis. So you get progressively less blanching as you burn away more of the dermis, because you're burning away more of the blood vessels. And these burns are often less painful. Often less painful in the area of the burn. So again, if we think of the skin here, the epidermis, the dermis, we know that the nociceptors are spread throughout the dermis. Then many of them are simply burnt away. Simply burnt away. So there's less nociceptors to perceive the pain. So the pain is often less in the deep dermal compared to the shallow dermal burns. But what we have in the skin, in the deeper layers of the skin, I should maybe show you on this diagram here, this one from the pathophysiology book. On the deeper layers of the skin, we have pressure receptors. And we see the nociceptors can be higher up. So what happens is, if you prick this with a sharp object, like a hypodermic needle, you prick the wound, instead of feeling pain as you would if these nociceptors were intact, the patient experiences a feeling of pressure. So you can stab them with something sharp and they can have a feeling of pressure rather than a feeling of sharpness, because these are the only peripheral sensory receptors generating tactility that may be left. So often less painful, with a feeling of pressure rather than pain. Now, healing in these wounds, there's a lot of tissue been lost, so healing is often more than 21 days. It can take a long time to heal. Now, the healing often takes place from fibroblast cells, which are found throughout the dermis. But of course, a lot of dermis is lost, so there's less fibroblast cells left to facilitate healing, because it's the fibroblast cells that produce the fibrous tissue to regenerate the dermis. It's the fibroblast cells that produce the collagen to give the tensile strength to the dermis. So you're starting from a low base, a low cell population, so healing is going to take longer, and as well as that, there's a much greater thickness of skin that requires healing, so it's going to take more time. Healing often occurs by granulation, the development of granulation tissue. Now, we've looked at this in great detail if you want to look at the series on wound healing, Campbell teaching series on wound healing. But the fibrosis, the healing by fibrosis, remember, if we can't heal by regeneration, if the tissues are so badly damaged that there's not much left there to regenerate by mitotic regeneration, then we're left to healing by fibrosis, collagen scar tissue, and the fibrosis leads to scar tissue. And this leads to poorer cosmetic and functional results. So these bones are more likely to heal with scar tissue formation. And as in all burns, as we've said, infection is common, but infection is particularly a problem with deep dermal partial thickness injuries. These burns are likely to get infected. That's going to further delay wound healing, can actually increase the size of the wound, and make no mistake, there is a risk of sepsis. Systemic sepsis is a risk with burn injuries, and people can die from it, of course. So very often what we do in plastics units or burns units is skin grafting, split skin grafting. So in a split skin graft, healthy skin will be shaved off from a part of the body. Split skin graft, splitting the dermis. This top part will be taken and grafted onto the damaged burn. And very often you get very good results with this, as long as the recipient area is well prepared. So, swelling and fluid loss, red or white, sometimes wet, but can be a dry, waxy appearance, reduced or absent blanching, often less painful, feeling of pressure, very often because of the preserved pressure receptors deeper down in the skin when the dermal nociceptors have been burnt away. Healing can be very problematic. They need a lot of intervention, a lot of measures to prevent infection. Granulation tissue would want to promote. Fibrosis is a problem, resulting in scar formation. and the omnipresent risk of infection with, can't really stress this enough, there's a risk of sepsis. Burns can kill you, make no mistake. And often in special units these will be treated with split skin grafting. So the next classification of burn we want to look at are the full thickness or the third degree injuries. So burns, full thickness or third degree. Now in these burns, all the thickness of the skin is lost. So as we know, we have the top of the skin, the epidermis and the dermis. So the dermis here, the epidermis here, and we have hypodermis below here. The subcutaneous tissues below the skin. Now in a full thickness burn, all the thickness of the skin is lost. So all of this is lost, the totality of the skin. All of the epidermis, all of the dermis, all lost. They are full thickness burns. So clearly the most serious sort we've looked at so far, because more tissue is lost. So these are burns which extend to the subcutaneous layer, all the way down to the subcutaneous layer. And they have a significant infection risk. As we've discussed with the partial thickness injuries, infection is a big risk with burns. And the appearance of these can be variable. Very often they can look white, especially initially, depending on what caused them actually. Other times they're charred. I mean, if it's pure heat, there's nothing to blacken it really. Very often they just look like a dead, waxy sheet of tissue, dead tissue. But they can appear black and charred. Sometimes this waxy appearance, and they can kind of look like leathery, like old leather. So different appearances. And you can probably work out by now that, as we've said many times so far, skin, epidermis, dermis, the blood vessels are in the dermis. Arterial capillaries, venules, but all those are burnt away. This no longer exists in the burnt areas. So there's going to be no blanching. So when you press, you don't get any reperfusion, because that reperfusion you're seeing is coming from the vasculature in the dermis, and the dermis is gone. So we're not going to get the blanching. So no blanching, indicating full thickness injury. Now, as well as that, the nociceptors, as we've seen several times, are all in the dermis, and they're all lost. So again, when you put a sharp pin, when you prick the bone with a sharp pin, there's no nociceptors to feel the sharp pain. The nociceptors that were there are all burnt away, they no longer exist. But the pressure receptors, some pressure receptors are very low, even in the hypodermis. So sometimes pricking with a sharp needle can give a feeling of deep pressure from preserved pressure receptors low down. And because the nociceptors are all burnt away, there's less pain. So there's less pain. But if we consider an area of tissue if there's a necrosed area here of full thickness injury, then very often there's areas of partial thickness injury around about it, and they'll certainly be painful. So what we might notice, if there's shallow partial thickness in an area here, that will feel sharp when we put a needle, prick it with a needle. But in the middle it will feel just a feeling of pressure, meaning we're able to identify which parts of the burn are full thickness and which parts of the burn are partial thickness. And of course the painful areas, the surrounding areas with the nociceptors, will be very painful, whereas the area in the middle, the full thickness area of burn, will be less painful. Because the nociceptors are in the dermis, very few nociceptors in the hypodermis in the subcutaneous tissues. So less pain in the full thickness area of the wound, but certainly pain round about it. Healing from the wound edges. Now, if an area of full thickness, if there's an area of full thickness burn as we see here, then there's no keratinocytes to heal the wound by regeneration, by mitosis. They're all gone. And again, the fibroblasts, which can generate new dermis, or the blood vessels which can generate angioneogenesis, they're all gone. Everything's gone, so we can't replicate it. It's this idea of having no rabbits in a field. You can't get rabbits from no rabbits, and you can't get cells from no cells, so the tissue can't recover. What you can get is healing from the edges in. So viable tissue round about here would be viable living tissue. The area of the burn, of course, the tissue is all necrosed, it's all dead. But we can get migration of living cells into the burnt area, and you can get very slow healing from the wound edges. This works okay for relatively small burns, but for big ones it's not really a viable modality of healing. Full thickness burns, we get more fibrosis, more healing by scar tissue. The fibrosis means we get scar tissue. The scar tissue means we get contractures, because as scars mature, they contract. So scars are actually contractile. They're a bit like muscles. They're contractile. They get smaller with time. And so, for example, if they're over a joint, that's going to contract, and it's going to take away the nice elastic skin that we should have over a joint and replace it with rigid tissue, causing claw-like contractures in the hands, for example, and in other parts of the body indeed, depending on where it is. And the other risk with full thickness burns is we get coagulation necrosis. So you know blood coagulates, it clots, doesn't it? So the heat will coagulate the proteins, it will cause denaturing of the proteins. And that's what actually, so the proteins in all of this tissue are denatured, and that kills it, causing necrosis. Dead tissue necrosis. So coagulation necrosis, and that can form an S-scar. Now what an S-scar is imagine there's a burn. Let's imagine this is the burn. Let's imagine this is the burned area here. Now this represents the burn, this old cloth here. Now this was living skin, but now it's burnt, it's coagulation necrosis, it's dead. So what you have is a whole layer of dead tissue over the surface of the viable tissue which is beneath, in this case in the hypodermis or deeper structures, because the full thickness is all burnt. But there's still things that bacteria like to eat in this, and there's still nice warm places for bacteria to hide. So this is associated with a very high infection risk. And many plastics units will just get rid of this, they'll just take it off and graft the tissue beneath. But if you don't, and there is no, if they get away with the infection, that will separate within 2 to 3 weeks anyway, because it's dead. So that's what we mean by S-scars. but they're associated with a particularly high risk of infection. So in burns units, very often this tissue will be debrided down to healthy, viable, bleeding tissue beneath. So 3rd degree burns, full thickness injury, meaning the full thickness of the skin is lost. And if we think about what that means on this diagram that we've been using from the pathophysiology book again, what it means is everything is lost. The epidermis, the dermis. So the hair follicles are lost, the sweat glands are lost, the nociceptors are lost. That's why if it heals by fibrosis, all these elements will no longer be present. There won't be generation. There won't be regeneration of these elements, there'll just be scar tissue. So the tissue will be scarred, it'll be contracted, it will be unsightly, it'll be non-functional, it'll be non-elastic. Won't have hair, won't have sweat glands. Because all of this is lost. Unless it's relatively small and can heal from the outside in. So a burn of this sort of size, imagine that green bit was the burn there. If that was a real size. Just compare that to part of me to get the idea if that was real size. Then that could heal from the inside and you could get regeneration there. But if larger areas are lost, then skin grafting is the only option really. If we don't want completely fibrosed, non-functional, poor cosmetic results, we will need skin grafting at an appropriate surgical unit. So burns are a form of trauma. So we always in trauma have to think about our primary survey, A, B, C, D. Airway with C-spine control, breathing with ventilation, circulation with hemorrhage control, disability for neurological function and status. Now, people that are subject to burns have often been in an environment where things are burning, fairly obviously. This is especially true with car fires and house fires. And these patients can come in and they really stink of the fire, you can really smell it. So first of all, we need to think about airway patency. Does the patient have a patent airway? Now, if the patient has a low level of consciousness and we're fairly satisfied that there is no C-spine involvement, then we'll do the normal head tilt first aid procedures. If the patient's got a low level of consciousness, we might think about adjunct airways, such as a Goodell airway, or possibly even endotracheal intubation, if the patient had a very low Glasgow coma scale. Or if we did suspect C-spine control, we would probably think about doing the jaw thrust manoeuvre, as we do in any sort of first aid immediate situation where we want airway patency. But apart from that, there's particular problems in burns with airway patency because the patient's been inhaling hot gases. There can often be inhalation injury. So the patient's been breathing in the hot gases from the fire, they've been breathing in the smoke that's generated by the fire. And heat, of course, can cause inflammation, and the inflammation can lead to potentially significant airway edema. So the hot gases insult the lining of the respiratory passages inside the nasal passages, inside the oral cavity, in the pharynx, in the trachea, in the bronchioles, all throughout the airway tract. There's the potential for airway edema. And of course this is massively important because if we think about the airways, here we have the trachea and the mouth, and above this we have the nasal cavity. So we have the nasal cavity there for air to go in and out, the oral cavity where air goes in and out, branching into the right and left main bronchus, branching into the smaller bronchial passages. which do become progressively smaller as we go down into the bronchial tree. And there's the potential for these hot gases to come into contact as they're inhaled with all the linings they come into contact with. So the oral lining can become inflamed, the nasal cavities can become inflamed, the pharynx. There can be inflammation here. And inflammation leads to heat, pain, swelling, loss of function. And further down, and with the smaller airways, again, relatively small amounts of inflammation. If there's inflammation in the walls of the airways, that inflammation is taking up space and is going to close down and reduce the lumen of the airways. So this massive airway edema that can develop is particularly important because the edema is going to reduce the lumen of patent airway that is left and can lead to asphyxiation. So we have to be on our lookout for this possible inhalation injury, especially in patients that have been taken out of a burning environment. So we're going to look at the voice if the patient's conscious. Is the voice becoming hoarse? So the hoarse voice would indicate inflammation in or inflammation of and around the vocal cords, which of course are at the top of the trachea. Or is the patient spitting out carbonaceous sputum? Is there carbon in the sputum? Which again would indicate inhalation of smoke, and smoke can often be superheated, meaning that there's a likelihood of inhalation thermal injury. Or what about burns around the mouth or burns around the nose? Again, these could be caused by hot gases, and if the hot gases are burning the mouth and the nose, then it's reasonable to assume that they're also burning the lower parts of the airway. And look in the patient's nostrils. See if the nasal hair is singed, because if it is, the patient has been breathing in superheated gases. Also look out for stridor. So stridor relates to upper airway noise during ventilation. Stridor. And this can be evident even if the patient is unconscious. We can hear the upper airway, the stridor, as the air struggles to get past the obstruction in the upper airways. We can hear the stridor. And all of these things are going to reduce the ability of the air to get in and out of the patient's lungs. So they are an obvious threat to the airway. And as well as the first aid airway management, what we tend to do is give intravenous hydrocortisone at an early stage in the hospital situation. Because the hydrocortisone is a corticosteroid type molecule, and it's going to massively reduce the inflammation. Because if we've got these things at an early stage, if we've got history of inhalation injury, if we've got hoarseness, carbonaceous sputum, burns around the mouth or nostrils or of the stridor, then that means the inflammatory process has begun, and the inflammatory process will continue for a period of time. And as the inflammatory process continues, the swelling will become greater, and the risk of airway obstruction and death from airway obstruction is there. So very often, prophylactically, we can give intravenous hydrocortisone to prevent this. So thinking about the airway management, massively important. And still thinking about breathing, if there's circumferential burns, these are burns that go all around the body. So if there's burns that go all around the body, particularly around about the thoracic cavity, even the abdominal cavity, it makes expansion for ventilatory effort more difficult. Because of course we're only going to suck air into the lungs when the diaphragm goes down and the intercostal muscles pull the ribs up and out, we need these mechanical movements. And these can be inhibited in circumferential burns, although this is usually a later complication, but it's something to keep an eye on. Now, thinking about things that are inhaled, fires, of course, produce carbon dioxide, but they also produce CO, carbon monoxide. So carbon monoxide is just CO, not CO2 as in carbon dioxide. And the thing about the carbon monoxide molecule is it has a very high affinity for the hemoglobin molecule. So it's the hemoglobin molecule that transports the oxygen around the body, as you probably know. So normally in the lungs, the oxygen will combine with hemoglobin in the red cells, forming bright red oxyhemoglobin. This will circulate to the tissues, give up a proportion of its oxygen, and return to the lungs in a somewhat deoxygenated form, a deoxyhemoglobin. But the carbon monoxide occupies the normal receptors in the hemoglobin molecules that bind the oxygen, and it just sits there. It's got a high affinity for it. So once the carbon monoxide molecule is there, it'll just sit there. It won't be released. So the carbon monoxide will form this compound with hemoglobin called carboxyhemoglobin, and that will be formed because the carbon monoxide has gone into the lungs, gone across the alveolar membranes and formed this carboxyhemoglobin. But when the carboxyhemoglobin goes to the tissues, it won't give up the carbon monoxide to the tissues, as the oxygen would be given up. And when the carboxyhemoglobin returns to the lungs, again the carbon monoxide does not diffuse from the blood back into the alveoli as the carbon dioxide would, because the carbon monoxide is firmly bonded to the hemoglobin molecule, and it's occupying the carrier site. So blood which has carbon monoxide in it, hemoglobin molecule which has carbon monoxide attached to it, is completely incapable of carrying any oxygen whatsoever, therefore for a period of time becomes essentially useless. So we need to look out for this carboxyhemoglobin. And of course in hospitals all the time we put on our oxygen saturation probes, look at the patient's blood oxygenation levels, and in the case of carbon monoxide poisoning, these are completely useless. They don't work. So if someone has a lot of carboxyhemoglobin, they're unable to transport oxygen to their tissues. It's basically a form of blood-caused hypoxia, that the oxygen is not getting to the tissues because the blood is incapable of transporting it. But this will not show on the oxygen saturation probes because oxyhemoglobin and carboxyhemoglobin both absorb the laser light of our oxygen saturation probes in the same way. So if someone's blood is highly saturated with carboxyhemoglobin, they will, on the oxygen saturation probes, they'll have an apparent oxygen saturation of maybe 100, and we think, oh, everything's fine, the sats are 100 or 99 or something. But no, the oxygen saturation probe is not picking up oxygen in the hemoglobin, it's picking up carbon monoxide in the hemoglobin. So the current generation of SATS probes are useless, so we have to use our clinical judgment. Does the patient have headache, indicating cerebral hypoxia? Are they nauseated? Are they confused from cerebral hypoxia? Is there coma? And that can lead to death. And there can also be a cherry reddish discoloration of the lips, and there can also be a pinkening, that the skin can look pink. You get a pink discoloration of the skin with very high levels of carbon monoxide. Very dangerous gas. Doesn't smell, colourless, isn't detected by our saturation probes. So we have to recognise it clinically. And what we do is we give these patients very high flow oxygen, because very high flow oxygen will knock off some of the carbon monoxide from the hemoglobin, giving us some of our haemoglobin back. So we put these patients immediately on very high flow oxygen. And in fact, in some specialist centres, they'll even use hyperbaric oxygen. And as well as that, of course, putting the patients on high flow oxygen means that any haemoglobin that is left will also be fully saturated. Any haemoglobin that's left that is not occupied by carbon monoxide. But the high flow oxygen will knock off some of the carbon monoxide molecules, restoring the ability of the patient's blood to transport oxygen. Very important consideration. And other thing just to mention, other noxic fumes. I mean, depends what's burning, but anything can be given off. Particularly toxic fumes such as cyanide can be immediately life-threatening, and there's longer term effects from other nasty things in burning plastics, for example, such as dioxins. So starting to think about the systemic considerations in burns, remembering that burns are a trauma and are essentially treated as any other trauma, but with these particular considerations with regards to airway management and breathing. Well, it's time for my breakfast. Nice egg for breakfast there. And what we notice, of course, is the yellow yolk in the middle and the clear part around the outside. Now, that clear part around the outside is primarily albumin. It's nearly all albumin, actually, and we can see it's a clear protein, very high in protein, albumin. The key thing we notice here is it's clear. We can see the colour of the white frying pan quite clearly beneath that. Albumin is a globular protein. It's very common in human blood. It's the most common plasma protein. And it's a water-soluble protein. But the thing is, now I'm heating it up on my cooker. So what's going to happen is the protein, as it heats up, it's going to denature. So we have viable protein here that's in the process of denaturing, changing its nature. The organised protein structure is becoming disorganised. And as we heat it up, the protein which was in a living physiological form is now going to change and become denatured. And it's going to necrose. If it was living tissue, this would be necrosing. And we can see it's starting to go white. Move it a little bit so we can see better. We all seem to manage to break the yolks of eggs. It seems to be going well today. Just doing it slowly. So we can see it's now going from clear to white. It is necrosing. Now if this was a burn, that central area would be the area of coagulation necrosis. That protein is actually coagulating. And coagulating means it's going from a liquid state into a solid state or a semi-solid state. So if this was living tissue, it would now be dead. It's coagulated. Round about that, of course, we'd have the zone of stasis where there's reduced blood supply, and round about that we'd have the zone of hyperemia where there's inflammatory changes. So you can see clearly now we've gone from that clear albumin, it's now denatured, it's now necrosed, it is now dead. It makes it nice to eat, of course, but it's actually a completely dead tissue now. It's gone white, denatured, necrosed. That can never come back to life again. The complex protein structure I have completely destroyed with heat. So in this video we're thinking about burn zones, the areas of the burn. And the first area we want to consider is the area where there's actually necrosis and death of tissue. Now in this area there's been coagulation. coagulation zone, where the tissues have actually been killed, necrosed, coagulated, and they're lost. The proteins are denatured. But round about that, we have another zone where the circulation has been inhibited, but the tissues have not been killed. And this is called the stasis, or the zone of stasis, where the blood supply is reduced, but the tissue is still viable. And round about that, we've got another zone here, where there's been some insult to the tissues. There's inflammation in this area. So this is the zone of, and in inflammation, of course, we get redness, the hyperemia. So that's the zone of hyperemia. So we have these distinct zones. These are three-dimensional, of course. They go into the depth of the burn as well as round about the side-to-side direction. So it's a three-dimensional burn. So coagulation is dead, zone of stasis, reduced blood supply, zone of hyperemia. And we need to think about the implications of this. So this model of burn pathophysiology, so burns, we're really thinking about the pathophysiology of burns. And this three-stage model is based on the work of Jackson, who published way back in 1947. Douglas Jackson, the English research plastic surgeon. So we've got the area of coagulation. The coagulated area where the proteins have denatured. Proteins are lost, the area is necrosed. So here we've got dead cells and tissues. They can't be recovered. No recovery possible. So this really is the primary injury. And the size of the injury is going to depend on the heat of the object it came into contact with and the duration of that contact, as we would expect. Now the next zone is the zone of stasis. Now this zone of stasis here, just remind ourselves of the original diagram. So the coagulation zone and the zone of stasis. So the coagulation zone we did in green, and the zone of stasis we did in this orangey colour. Right, now this zone of stasis is kind of up for grabs, as it were, because this is an area of reduced perfusion. Not no perfusion like this, where everything's dead. There's reduced perfusion in this stasis zone, and that means there's a risk of necrosis. But if we can reverse the ischemia, if we can reduce the ischemia, then this tissue can remain viable. And this makes a huge difference, because it means that the final burn, if we lose this area, will be that size. Whereas if this area can be salvaged, we're only going to get a burn of that size. Only the coagulation zone itself will be the final area of burn injury. And this explains why it's so important locally and systemically to increase perfusion of this area of stasis round about the burn, and that will maintain oxygen, and the perfusion will also bring nutrition, because burns are very energy requiring wounds to heal. They need a lot of energy to heal. So we want to keep this area, once it's been once all the heat's gone out of the burn after the first aid situation, we want to keep that actually relatively warm to increase the perfusion. And of course it means we need to prevent systemic hypoperfusion. We need to keep the patient well hydrated, plenty of fluids on board, keep the blood circulation going round this area of stasis. And then that area should not necrose. We should retain that area. We can salvage it. But it is up for grabs. It largely depends on the management, how well the area is managed. Then the final area, the area of hyperemia. In the States, of course, you don't have that A as we do in the UK. The area of hyperemia. Now, this is where there's an inflammatory reaction. So this really is an inflammatory zone. There's hyperemia because of the vasodilation as a result of the effect of the inflammatory cytokines. And in the diagram we drew that as red. So the inflammatory zone, actually an area of increased perfusion. Now there's still probably a degree of tissue insult because we've had an inflammatory response, but here we do expect a full recovery of this tissue. And we would normally expect that to recover, unless things that can damage it, like sepsis, if the patient becomes systemically septic, or this area becomes very ischemic. Then it can be lost if the blood supply is greatly reduced in ischemia. So that's basically the Jackson model, the coagulation necrosis zone, the stasis zone and the hyperemia zone. And the reason it is so important is because although the coagulation zone is lost, we can't get that back, that's all dead. We can retain the integrity and the perfusion of the zone of stasis. So all this area here can be saved. The tissue can remain viable, will not necrose, therefore no healing will be required, as long as we maintain good perfusion, oxygenation and nutrition of that area. And unless we're very unfortunate, this area would expect full recovery, the inflammatory zone, unless we're very hypoperfused, very ischemic, or the patient becomes septic. Carrying on with our thinking about the systemic effect of burns, we're coming to C for circulation. Now, burns are very insulting wounds, and there's a lot of inflammatory mediators released from damaged tissues and insulted tissues around the area of a burn. So histamine, serotonin, prostaglandins, of course, complement, kyanins, a lot of pro-inflammatory mediators are going to be released from a burn. And these pro-inflammatory mediators lead to what is called capillary leak syndrome. So as you probably know, we have capillaries, small blood vessels, individual vascular endothelial cells comprising the wall of the capillaries. And this is true to the arterioles, the venules, the very small vessels, very thin walls. The arterioles will have a bit of smooth muscle around the outside. And the blood, of course, goes through these, very often only one red cell at a time, perfusing the tissue. Now, when we get these inflammatory mediators, when the inflammatory mediators are acting on the capillaries, so there's damaged tissue and there's going to be the release of inflammatory mediators in the tissues. Then what happens is these capillaries greatly dilate. There's actually two things happen. There's dilation of the small blood vessels like the arterioles and the venules and the capillaries, but also the inflammatory mediators actually cause the cells themselves to get smaller and fatter. They actually contract. This is a very much a deliberate process. So what we have is that the capillaries dilate. Cells get smaller, and we can see that this capillary is now quite a bit wider than it was prior to being exposed to the inflammatory mediators. Now, typically the larger gaps here are not big enough to let the red cells out. They still stay in, typically, unless it's very severe. They normally stay in. But it lets all the other bits and bobs out. So it lets out all the tissue fluids. Basically all the components of the blood that aren't the red cells can get out. So we can get water getting out. We get proteins. We get the nutrients. And of course, it makes the bigger gaps make it easier for the white blood cells to get out, particularly thinking about maybe the monocytes and the neutrophils, so the leukocytes. Vital, of course, to the protection of the body from infection. So it's a good thing because all these useful things get out. We need proteins, we need nutrients, we need water, we need leukocytes to help with the healing process. So that's good. That causes inflammatory exudate. But this is called capillary leak syndrome. That these capillaries become leaky. And what this means is that there's a shift of fluid from here, from inside the intravascular compartment. So that's the intravascular compartment there. Intravascular means inside the vessels. And the fluid instead collects in the interstitial compartment. The interstitial compartment, or the third space. Now this term third spacing, so interstitial compartment is a third spacing effect. Now what this term third spacing means is that the body water, most of the body water is inside the cells. So there's huge amounts of water inside, most of the water in the body is inside the cells. Intracellular compartment. And then the second compartment is the water in the blood, that's the intravascular compartment. And then the third compartment, or the third space, is anything that's not in the cells and not in the blood vessels. So if it's in the tissue spaces, that's in a third space. And the key thing about this is that when fluid is in the third space, it's no longer able to circulate around the blood. And it's useless for the purposes of sustaining intravascular volume and blood pressure. Now, this effect is always there locally. There's always going to be production of tissue fluid locally, and we expect this. Of course, this is edema. We get edematous swelling in an injury. But if there's a large burnt area, then the damaged cells and tissues in the burnt area will release inflammatory cytokines locally, of course. We know that because they're the ones that cause the initial vasodilation here. But as well as that, if there's a large area burnt, what we'll get is pro-inflammatory cytokines produced in large volumes, and these will then also go into the systemic circulation, and we'll get a systemic effect from this. So we'll get a systemic capillary leak syndrome all over the place. And the patient will become edematous and around about the area of the burn, yes, that's true. But also if there's like 20-30% of the body surface area burnt, they're going to become edematous all over the place because of this widespread capillary leak syndrome. And the bigger the amount of body surface area burnt, of course, the worse this is going to be. And if there's lots of fluid going from the intravascular compartment into the interstitial compartment, there's going to be less fluid left in the intravascular compartment. And of course, if there's less blood in the intravascular compartment, the fluid volumes are low. That's going to lead to hypovolemia. And hypovolemia, of course, is going to cause shock. Shock is when the blood pressure or the state of the circulatory system is so poor it's no longer able to perfuse and oxygenate the tissues. Cause of shock. And that's why these patients, patients with burns, we get these hypovolemia effects. People with burns are very thirsty. Very often the first thing they'll say is, can I have a drink, because they're hypovolemic, stimulating the thirst centres in the hypothalamus. And of course, if there's a reduced blood supply going through the kidneys, reduced renal perfusion, because there's less blood accessing via the renal arterial system, reduced perfusion, hypoperfusion of the kidneys is going to lead to reduced urine volumes. And of course, we have to make sure that we get 0.5 mils of urine per kilogram of the patient's body weight per hour. Otherwise, we're at risk of acute kidney injury, which we certainly don't want. And as well as losing the body's own physiological fluid in large area burns, the capillary leak syndrome can persist for some time, and the fluid that we give, 50% of infused fluid is lost into the third space. In the first 6 to 12 hours it's worst. And this means that a lot of the fluid we're putting in to maintain intravascular volume is actually going to contribute to the edema. But we still have to give fluid, of course, because otherwise the patient's going to become hypovolemic, shocked, and they're going to die. And we always need to think about electrolyte disturbance whenever we're thinking about fluids. And when there's injury, inside cells, there's a lot of potassium. Not so much potassium. I mean, normal serum levels of potassium are 3.5 to 5 millimoles, relatively low. But inside the cells there's lots of potassium, so when cells are injured, when the wall of the cell is disrupted, that potassium can get out. And we're going to get movement of potassium from the intracellular space to the extracellular space where it can circulate. Release of intracellular potassium. As you probably know, that can be really quite dangerous, because that can lead to hyperkalemia. And rapid changes in potassium are life-threatening. They can cause ventricular fibrillation, for example. And we also mentioned that lots of proteins are lost from the intravascular compartment into the edema. And this protein loss can lead to hypoproteinemia. Low levels of protein in the blood, particularly the albumin, of course, is the main osmotic protein in the plasma generating oncotic pressure. So we can get reduced plasma oncotic pressure. Now, as you probably know from other videos, the tissue fluid is produced at the arterial end of the capillary because the hydrostatic pressure of the blood is greater than the osmotic pressure. And tissue fluid is reabsorbed at the venous end of the capillary because the oncotic pressure generated by the plasma proteins is greater in the intravascular space than it is in the interstitial space. I'm not going to go into that in great detail here, but that physiology is well covered in this series on capillaries. I've covered that in great detail. But if we have reduced amounts of plasma, what it means is less tissue fluid is reabsorbed. So normally it's the plasma proteins here that are causing the tissue fluid to be reabsorbed. And if we have lower amounts of plasma proteins here, we're going to reduce the oncotic pressure. Less tissue fluid is going to be reabsorbed. Therefore, more fluid is going to be left in the tissues. So again, that contributes to the edema problem in the initial management of burns. And as we say, the larger the area of burns, the greater this systemic edema problem is going to be, with the capillary leak syndrome and the hypoalbuminemia. So this is 20% burns, this is going to be a problem. 30% burns certainly, and bigger area burns, it's a massive problem. Smaller burns, the systemic effects are of course less, and when the patient's thirsty we can simply give them drinks of water, which is good. Now I think in circulation, I'll just mention one other thing here. Compression effects. So all this edema can cause compression of the venous circulation especially, and that can reduce the perfusion locally. So compression effects can reduce perfusion locally. And this is particularly a problem with circumferential burns. So if I'm burned all the way around there, then that's going to reduce the circulation to my hand, circumferential burns. So we need to monitor distal perfusion. And the other big risk with circumferential burns, again, especially if they go all the way around, especially in the limbs, is the risk of compartment syndrome. So we have to look out for localized ischemia, and bear in mind the risk of compartment syndrome. In compartment syndrome, of course, there is an increase in pressure in the muscle compartment. That can preclude the circulation to that muscle compartment, meaning that the muscle in that compartment will die and it won't recover. So observe for local effects. So we see that we need to observe for local effects and systemic effects, and that when local effects become widespread, the release of the pro-inflammatory cytokines is going to have systemic complications. The rule of nines is about body surface area. How can we approximate the body surface area involved in a particular burn? And using nines, we can do that very simply. So this is the front and this is the back. So the head, all of the head is 9% of body surface area. That means the front of the head is going to be 4.5% of body surface area, and the back of the head is going to be 4.5% of body surface area. Now the arms, a whole arm, an entire arm is 9% of body surface area. So again, you can see that means we're going to have 4.5% for the front of an arm and 4.5% for the back of an arm, 9% altogether. The legs, again front and back, so a whole leg, an entire leg is 18%. And that means the front of a leg is going to be 9% and the back of a leg is going to be 9%. Half a leg obviously is going to be 4.5%. Now the torso at the front is going to be 18%, the whole torso 18%. So half a torso is going to be 9%. So the chest is 9%, the abdomen is 9%. And the back includes the buttocks. Again, 18% in total for the back, including the buttocks. So again, the thoracic area 9%, the loin area and the buttocks 9%. Do your sums, add 1% for the groin, and if I'm right you'll have 100%, so fairly simple really, the rule of 9, but quite clever. Now of course I didn't work this out for myself. This is based on the rule of Wallace, 1951, published in the Lancet. Because of course we don't work these things out for ourselves, we only teach and practice because we stand on the shoulders of giants. In this case, Alistair Burns Wallace, appropriately named. Burns was his middle name. So it's important to understand body surface area. And this applies really quite well if people are over the age of 16 and aren't too obese. If they're very obese, you need to make some adjustments for the alterations in body surface area with obesity. Now it's good for our overall understanding of the body, the proportions of it. But it's also important because if someone's got significant burns, maybe 20% or more, they're going to need intravenous fluid replacement. And it's important to know the body surface area of burn which is involved. And you're probably going to work out the volumes involved using the Parkland formula. Named after the Parkland, I think it's the Parkland Memorial Hospital in Texas, where this was developed by Dr. Charles Baxter, sometimes called the Baxter model, but usually we call it the Parkland formula, because we're going to need to maintain good hemodynamic stability with IV fluids after significant burns, normally starting with Ringer's lactate, what we call Hartmann solution. Now another way to think about this for smaller areas is, let's look at my hand here. So here, my fingers and palm down there, that is 1% of my body surface area. So we could take the person's hand, and any individual's hand, including the fingers there like that, is going to be approximately 1% of body surface area as another sort of rough and ready reckoner. Now there are more accurate formulas you can use, but this is a good quick appreciation. So let's just, actually I've got it written out here, let's just look at it. Entire arm 9%, entire head 9%, so half an arm 4.5, front or back of the head 4.5, entire chest 9%, entire abdomen 9%, which makes 18% for the front. The entire back 18%. An entire leg 18%, so the front or back of a leg is going to be 9%, and the groin area 1%. Slightly different with children, it depends on the size of the child, and again there's specialised paediatric charts for working this out. But basically children have got bigger heads, so roughly if we say 18% for the head in a child, that would be 9% for the front and 9% for the back. 18% for the torso. The arms in children will count those as 9 each. So 4.5 for the front, 4.5 for the back. Again, the torso in a child, again we can count that as 18%. And in a child the legs will count as 14% each, as an approximation. So it's really surprising, really. Well, the body never ceases to surprise you, but you know, just that it's all divisible into nines, and that was identified by Wallace in 1951. 9s, 18s or 4.5s.